Thank you very much, Dr. Omatoshi and Dr. Kurian, and to the program committee for giving me the opportunity to speak to you today. Here are my disclosures. These are not relevant to my presentation this morning. And perhaps this is, I think, the more important disclosure that all bariatric surgery presentations should have, which is what is it that the surgeon actually does. And so about 20% of my practice is duodenal switch. And I think an important disclosure with regards to this presentation is that I do not personally perform the OAGB. And just out of curiosity, if people in the audience who can raise your hand if you actually do the procedure? OAGB. Good, so I can say whatever I want and nobody's gonna fight me. Great. All right, well, you've seen various iterations of this, I think, in every presentation with regards to the increase in sleeve, and again, highlighting the fact that revisions are increasing as well. I think probably about 5-7 years ago, most of these revisions were related to lap band procedures, but I think it's pretty clearly the case that the majority of these now are really related to sleeve gastrectomy. And this is another follow-up study with really 7 years, 82% follow-up from Chile, looking at the weight loss over time, and you can see that gradual decay. But I think that another thing that's really important when you look at these longer-term studies is looking at individual patients and how many of them actually achieve that 50% excess body weight loss, which, as you heard earlier, is a questionable metric in and of itself. But in their series, they found that over 50% of patients failed to achieve 50% excess body weight loss at 7 years. So the sleeve is a good operation, but it does have its issues in terms of durability. And in terms of describing failure of an obesity operation, I know we don't like to use that term. I think the more appropriate term is non-responder or inadequate response. Certainly if somebody has an intractable complication like reflux, that would, in my book, be considered a failure. How much weight loss is enough? Again, you heard about the shortcomings of that 50% excess body weight loss. I do think it's important to take into consideration comorbidity improvement or relapse of comorbidities, certainly quality of life. And as all these complex metrics might be, I kind of try to keep it simple, which is that if the patient is still a candidate for obesity surgery, that is, to me, a failed operation. And what about the patient satisfaction? Well, when you look at the studies to look to see whether patients are satisfied or dissatisfied with their obesity operation, if their BMI at 5 years post-op is around 30, they tend to be very satisfied. But the patients who are less satisfied end up with BMIs, again, in that range where they're still a candidate for obesity surgery. So the magnitude of the weight loss does matter to patients. It's not just academic or bragging rights that we as surgeons talk about. So we've talked a little bit about what the options are after sleeve, and re-sleeve, I think, is an interesting concept. I really reserve conversion to bypass for GERD and high chronic leak. I tend to convert these to standard DS if their initial BMI before the sleeve was greater than 60 or the residual BMI is greater than 50, or if they have recurrent metabolic disease. And then the topic of today's talk is really the comparing and contrasting conversion to OAGB or loop DS. Now, I do think that it's important to highlight that I'm not so sure that converting a sleeve to a bypass for inadequate weight loss is really a good approach. This is randomized prospective data, and you can see that while there is a statistically significant difference in the weight loss at 5 years, that BMI difference is really quite modest. And I think that we really need to ask ourselves, is this concept really an appropriate one if you're actually operating on somebody for inadequate weight loss? And the good news is that there's actually some data now, and this is a meta-analysis comparing weight loss of conversion of sleeve to DS options versus Roux-en-Y gastric bypass. And so in the forest plot on the top, you see that there's a favorability towards conversion to DS and loop DS, with no significant difference in the adverse events in this meta-analysis. So I think this is pointing us in the direction that we should be going when thinking about inadequate weight loss. And in fact, people are marching with their feet. If you look at the amount, the percentage of increase in revisional DS over the last few years, it's been substantial. And so I think that the good thing here is I think people are starting to follow the data. So just a couple points about the anatomy of these two operations. With regards to converting sleeve to loop DS, standard descriptions of the loop DS oftentimes talk about a larger bougie size, whereas with the primary sleeve, we tend to use a smaller bougie size. But keep in mind that when we're talking about surgery for inadequate weight loss, the patient has been able to compensate adequate intake and so forth. So the sleeve size really is not so much of an issue. I think one of the key things with the OAGB from a technical perspective is the description of the transection starting just distal to the crow's foot. And so it's really quite a long, narrow pouch, which for those of us who perform the standard gastric bypass, it's a concept that we need to constantly remind ourselves that differentiates the OAGB from the standard gastric bypass. Here's a conceptual description of the different limb lengths and the relative proportionality of the biliopancreatic limb and common channel and so forth with the gastric bypass and with the standard duodenal switch with the red ring representing the pylorus. And I think that when we talk about limb lengths and so forth, we always have to be thinking about it in the context of the total small bowel length, because that really does drive some of the weight loss as well as leads to some of the nutritional challenges with these operations. And so when thinking about it that way with these loop procedures, with the loop DS, the efferent limb is the one that tends to be standardized, usually between 250 and 300 centimeters long. So the afferent limb, the biliopancreatic side, if you will, tends to be quite long, whereas with the OAGB, that biliopancreatic limb, it's certainly longer than with the standard gastric bypass. It's usually between 150 and 250 centimeters long, but a much longer efferent limb. And so understanding those differences, in addition to the differences in the pouch configuration, can lead us to think about what the conceptual differences and the potential concerns of the two operations really might be. And again, that small bowel length is a key one because it varies a lot from individual to individual. So this is a study looking at several hundred measurements of total small bowel length. And so you can see it's a pretty good Gaussian curve. It varies by patient height as well as gender. And so there are limitations to these fixed length approaches that we use, really more out of convenience than science, because it's not always so easy to measure the entire small bowel length. So in the absence of a great deal of data comparing the two operations, here are some technical considerations and concepts in terms of sleeve to loop DS versus sleeve to OAGB. So one of the potential advantages of conversion to the loop DS is that you can avoid adhesiolysis. You can leave the sleeve totally alone and just go to work on the duodenal dissection. But having said that, there are understandable concerns and hesitancy, and for most obesity surgeons, a lack of direct experience with duodenal dissection. And so I think that most people would feel more comfortable with the transection just distal to the crow's foot on the sleeve itself. From a physiologic perspective, I think that preserving the pylorus does have its advantages in terms of potentially reducing some of the reflux as well as reducing dumping symptoms and so forth. But again, there's the technical aspect of the duodenal dissection. Measuring the small bowel length in an antegrade fashion from the ligament of Treitz is a lot easier. You don't have to switch sides of the table to do the measurements and so forth. And so that's a relative advantage of the OAGB. And then finally, the issue of marginal ulceration. Remember, the reason why the DS has that duodenal cuff in part is that that's more resistant to ulcer formation in the long term, and so that may be a potential advantage. So what do the data show with regards to the effectiveness of sleeve to OAGB? So this is one study looking at 32 patients who had a sleeve gastrectomy, and you can kind of see the trajectory here. So they reached a nadir at the time of the revision. And what you see is the conversion to the OAGB, and interestingly, they used a 250 centimeter biliopancreatic limb, which is much longer than what sort of the standard OAGB now describe being between 150 and 200 centimeters. But even with this longer BP limb, while they did see some improvement initially, in the weight loss, it started to decay. I'd highlight in particular the green line here, which is the percentage of excess body weight loss, as well as the BMI line, which is red. And you can see sort of those trends in a relatively short period of time after the conversion towards some weight regain. And so in the absence of a ton of data, and with a particularly longer biliopancreatic limb, I think this is a little bit concerning in terms of our thought process about OAGB as the revision option after sleeve gastrectomy. There is a recently published study actually directly comparing the two options, loop DS versus OAGB with sleeve gastrectomy. It's an observational study, and the follow-up wasn't great. It's less than 60% at 3 years. So with this, with the loop DS, the alimentary limb, so the distance from the duodenal-ileostomy to the cecum was 250 centimeters, and in this case, they used a 200 centimeter biliopancreatic limb in the OAGB option. And you can see that there is a trend towards favorable weight loss for the loop DS as compared to OAGB, although both operations had a pretty decent weight loss. And interestingly, in the context of the Dr. Ma's presentation with regards to reflux, there was a better improvement of reflux following the loop DS as compared to conversion to one anastomosis gastric bypass. So obviously there's a lot of opportunities to really understand and investigate this further, and every presentation always ends with saying we need more data. But I think that the key thing here is to, and we have to take very seriously, are the nutritional considerations. I think that, with the terminology of mini bypass and so forth, or even a mini DS, I think that there's a tendency to underestimate the nature and potential issues with regards to nutritional complications afterwards. And I think that the whole concept and issue of bile reflux, both into the stomach as well as into the esophagus, is something that we really need to continue to follow. So thank you very much for your attention. I look forward to your questions.